Okay, I forgot to answer this question earlier. So Mr. Lewis asked this question during the break about why we're using anticholinesterase medications. So going back here on the pathophysiology in this figure, so the problem again is autoantibodies destroying the receptors, correct? So since the receptors are necessary for the transmission, so we have here acetylcholine, and then there's a mismatch, right? Because the receptors have been destroyed already. So therefore, when I move repetitively, yes, I can do that for a short while, but since there are millions of nerves between here and here, so can I sustain that movement? Because remember what happens is we have acetylcholine receptors, then cholinesterase will be produced to destroy acetylcholine. Now, since the problem is we don't have enough receptors, we can't fix this because they're already destroyed. So what we can do is why not prevent the destruction of acetylcholine. Okay, that way you have more than enough acetylcholine. So even if you don't have enough receptors, at least you did not destroy acetylcholine. So this will help sustain the muscle contraction. Does that make sense? Yes. Meaning you inhibit the production of cholinesterase. So that's why we give anticholinesterase agents. Does that make sense? Any question about that? Okay, let's go now to rheumatoid arthritis. What page was it? No, 17. Okay, I had it. Never mind. I'll just find it. It's 1078. Okay. Okay, so this falls under diffuse connective tissue disorders. So next semester, our next exemplar for this will be lupus. Rheumatoid arthritis is a very common disorder. Contrary to popular belief that it actually is an old person's disease, that's really referring to osteoarthritis. Rheumatoid arthritis can affect all age groups. So it doesn't only occur in old people. In fact, when you see old people that have rheumatoid arthritis, it did not develop when they got old. It developed years or decades before and then continued because it's chronic. So therefore, it continues on to the old age. Does that make sense? Okay. Meaning they didn't get rheumatoid arthritis after retirement. Okay. So they already had the disorder and then they had it forever. Are we clear? All right. So what is it? Again, autoimmune disorder. We don't know what causes rheumatoid arthritis. We do have risk factors. Here's the incidence. So that's a lot, right? 1 to 2%. So there are how many people in America? 330 million as of 2 years ago. So we're now at probably what, 340 million something? So 1 to 2% of that is how many people? That's still millions of people, right? Okay, that's a lot of people suffering from the disorder, and mostly females, okay, compared to males. So onset is between the third. So in your 30s to 60s is the age of onset. As with any other autoimmune disorder, we don't know why it develops. All we know is there are autoantibodies again, this time attacking the patient's joints. So they attack the synovium, causing destruction of the joints, resulting in pain, chronic pain. So it breaks down collagen, causing edema, fluid to accumulate in multiple joints. The joints affected here most commonly are the fine motor joints. Unlike osteoarthritis, which usually affects the weight-bearing joints, such as the hips, knees, rheumatoid arthritis, yes, they can affect those large joints as well, but they affect more the fine motor joints, such as the hands, fingers, the wrist. And if you look at the signs and symptoms, it's always symmetrical, meaning the joints they affect are always both wrists, both index fingers, okay, both shoulders, both elbows. Okay, it's always symmetrical. Unlike osteoarthritis, which usually is unilateral, meaning once you have, let's say, because osteoarthritis is wear and tear. So let's say you're a nurse, you've been a nurse for 30 years. So what happens to your back? Your knees. Okay, so usually one knee is worse than the other, right? Because once you have one bad knee, so you tend to favor the other, right? Meaning you try not to walk or stand on that painful knee. Okay, so that's the pattern in osteoarthritis. In rheumatoid arthritis, you have no choice because it's always symmetrical. So the joint pain and swelling, the inflammation affects symmetrical joints. So it's always both sides. The results of the labs, because it's not, there's no test, there's no one test, blood test or x-ray or CAT scan that will diagnose rheumatoid arthritis. All cases are diagnosed based on the patient's clinical presentation, because the results here, particularly the rheumatoid factor, for instance, rheumatoid factor, CRP-ESR, which are inflammatory markers, meaning they rise in the presence of inflammation, including ANA antibody, which is also present in MS, lupus. They are not exclusive to rheumatoid arthritis, meaning, yes, they are all elevated in rheumatoid arthritis, but so are other autoimmune disorders, meaning there's no exclusive test to diagnose rheumatoid arthritis. Does that make sense? So it's not easy to diagnose. So the doctor has to do, just like with myasthenia gravis earlier, there were other tests, but were they used to diagnose myasthenia gravis, or in this instance, rheumatoid arthritis? They're done to rule out other causes. Okay, so to say, oh, is this rheumatoid arthritis or is this lupus? Okay, so they do other tests. They also do EMGs, MRIs, just to make sure they're making a correct diagnosis. Okay, rather than, is this a spinal issue? Okay, is this a spinal nerve problem, or is this a neurologic problem? Okay, let's say, is this some form of polyneuritis? Okay, so they want to make sure that this is RA and not something else. You follow? Okay, so these are the manifestations. So early on, again, symmetrical joint pain, always both sides. Okay, never one or the other. Both wrists, both sets of fingers, from head to toe. So symmetrical joint pain, swelling, warmth, erythema, indicative of inflammation, chronic inflammation. Of course, with inflammation, fluid will form, okay, in the knee, in the shoulder, in the elbows, whichever joints are affected. So there'll be fluid accumulation there. Just like when you have, let's say, ladies who look like party goers here. Oh, Jennifer smiling. So she's a party girl. Okay, so Jennifer, when you have new heels, okay, new shoes for you go out party, what happens if you didn't get to break those in? You just got them this morning to wear tonight, or let's say tomorrow, Friday night. So you're gonna wear them tomorrow, and then you'll be on the ledge, right? Oh, woo, just dancing away. So what will happen, since those shoes are new? You didn't get to break them in. So what will you get at the end of the day? You get blisters, right? And what is inside that blister? Fluid. So same thing here. So whenever there's inflammation, there will be fluid. Okay, and it's painful, right? So here, as the disease progresses, so it starts from the small joints in the hands and then now affects larger joints over time: knee, shoulders, hips, elbows, ankles, and even the spine, or even your jaw. Okay, in some cases, it's always again bilateral and symmetrical. It's always both sides. Are we clear? Okay, so this is the distinguishing feature of osteoarthritis and rheumatoid arthritis. Over time, especially if the patient does not treat, because again, it's an autoimmune disorder. So what will be the nature of the treatment? Immunosuppression again. So there's side effects there, right? We just finished discussing side effects for treating. The first one we did was myasthenia gravis. So this is another one. So the patient will be taking similar medications, which will cause immunosuppression, causing, frequent illnesses. And especially when they get exacerbations, you take steroids. Who has taken steroids here for 2 weeks or more? How do you feel? You feel swollen, right? Bloated, okay, your ankles start to swell, okay, because your appetite increases, right? You gain weight and you don't like it, right? So it's not nice to be on steroids. So the joints are hot, swollen. So if the patient does not treat it, so deformities will result. The worst form will be swan neck deformity. If you haven't seen this, let me show you what it looks like. Although this doesn't occur overnight. So the over time, over decades of under or no treatment will destroy your joints, and then now they become like this. Okay, so this is from joint destruction, okay, from the chronic inflammation. So now tell me, how are you gonna do paperwork after you use the bathroom? Okay? How do you know what I mean, right? Yeah. Paperwork after doing number two. How are you gonna do that? How are you gonna close the buttons of your blouse? Okay, the door. Okay, driving a car holding the steering wheel. So it's difficult. Okay, so this is the end result. So is it disabling? Yeah, this is disability. Yeah, you can't take care of yourself anymore. How do you cook now? Turn on the stove, right? Carry laundry. Okay, so here, this is what's gonna happen. And this doesn't only occur in really, really old age. What if you're only 60 and you have these already? That's early retirement. Okay, that's early disability. All right. So it's not good. So this is something the patient should be educated on. You can do a sequence of surgeries to correct it, but that's another whole um, journey there. All right. So that's a lot of pain because it's not corrected with one surgery. So they'll have to do series of surgeries.
The medication for it just kind of slows down progress.
Yes, that's all we can do. As with any other autoimmune disorder, there's no cure for this one either. So what did we do in myasthenia gravis? Put the patient in remission, right? So you want to keep the patient as symptom-free for as long as possible. As with any other autoimmune disorder, same goal. Usually when these patients have rheumatoid arthritis, other syndromes follow, and these are a few of the syndromes that they have. So you've got arteritis, which causes, especially if you have arteritis of the temporal artery, so that will cause, inflammation of arteries. So it cause a massive headache, um, neuropathy, pain in the hands and feet, pericarditis. We'll discuss that under module 8, splenomegaly, and Sjogren's syndrome, dry eyes, dry mucous membranes, and I mean all mucous membranes, including the vagina, the rectum, okay, will be dry, resulting in painful intercourse, okay, painful everything. As I said, with diagnosing, there's not one test Okay, so look at all these. Again, the tests mentioned here are not meant to isolate, you know, to get a test, to get a definite diagnosis. So it's more to rule out other possible causes, right? So we can distinguish, oh, this is not hepatitis or this is not lupus, all right? Let's go straight to management. So what can we do with the patient? You've diagnosed with rheumatoid arthritis. So what are your choices? The goal of treatment, and what does this say? Thank you, Katerina.
Strengthen, while achieve clinical remission, and the likelihood of joint deformity.
Okay, thank you, Katerina. So early on, we will use a slew of medications. So the cheapest DMARD is disease modifying anti-rheumatoid therapy or drugs, is methotrexate. Comes in PO, also comes in IV, but most patients obviously are on PO methotrexate. Now, this drug is a teratogenic. So remember, people with rheumatoid arthritis, they can be diagnosed early, correct? So if you're, let's say, in your third decade, that's third and fourth decade of life. So that's still childbearing age, right? So you should make sure first before starting therapy that you're non-pregnant and you stay non-pregnant during the therapy. Because otherwise, of course, your infant, your embryo will be deformed. Okay. These are other options. Sulfasalazine. This is also very common in Crohn's disease. A treatment for Crohn's, sulfasalazine. And you've heard of hydroxychloroquine, right? This was very popular in 2020 when we had COVID and people were throwing this around, right? So it's a anti-malarial agent. We'll talk about this again when we get to lupus. Okay, because this is also used for lupus. Because lupus RA, they're both chronic autoimmune inflammatory connective tissue disorders as well. So as with any other disease modifying agents, meaning immunosuppressants, they all cause bone marrow suppression. So puts the patient at risk for infections. All right, so let's go to the next paragraph, which are more expensive treatments. So have you heard of half the commercials on TV are on drugs, right? And what diseases do they really treat? So they advertise Crohn's, right? They advertise ulcerative colitis, psoriasis, right? All autoimmune, right? Disorders. So meaning, why are drug companies able to, because those ads are millions of dollars per a minute, right? Or a few seconds, right? So why are they advertising them? Because do they get a good return? Yes, that means these drugs are very expensive. Okay, so that's the way they can afford those commercials. So a few on TV are, we got interleukin-1 or TNF inhibitors. Have you heard of Enbrel? Okay, and other drugs on TV are Humira, which is adalimumab. Okay, so that is an interleukin-1 inhibitor. TNF inhibitors are the Enbrel, a few other brands I can't remember, but they are very expensive. Okay? So, however, they're expensive because they are not broadly inhibiting your immune system. Okay, they are cell specific, right? So let's say these agents only cover TNF inhibitor, tumor necrosis factor alpha inhibitor, meaning these are only targeting inflammatory substances that are responsible for the symptoms of rheumatoid arthritis. Meaning they leave all the other immune system cells alone. Okay, so therefore, less side effects. That's why As a result, though, they are expensive. Okay, so these inflammatory markers, these are cytokines. Cytokines are pro-inflammatory substances responsible for the symptoms of RA and also of lupus, systemic sclerosis, multiple sclerosis. So they're very specific, cell-specific targeting drugs. We have a table for that. So you have some, I mean, there's really not much nursing you can do with rheumatoid arthritis. So all we can do here is drug therapy, which means most of your questions on exam 2 on RA will be on the drugs. Okay, so we'll test table 34-2. On the next treatment, thank you for reading this. Lewis. Sorry. This one's corticosteroid. Yes. Right here. Corticosteroid.
Corticosteroids are recommended as the early treatment, but are not recommended for long-term treatment due to side effects.
Okay, what does a bridge mean? Right, so you're doing 2 therapies at once. Okay, so until the methotrexate, azathioprine, or all the other disease-modifying anti-rheumatic drugs kicks in, you put them on steroids. But are you on steroids forever? No, only as a bridge, so only a couple weeks, okay, until they start working.
Mainline heparin and warfarin.
Yeah, same therapy. So we'll talk about that probably next semester.
This one is not for exacerbation. This is for.
Yeah, this is the initial treatment. So initially you'll be on steroids for a few weeks. Then after that, you'll just be on the DMARDs.
Alone.
Yes. Unless you get, let's say you don't follow drug therapy, or you can afford it, or you have experienced a stressful event in your life, then you'll have exacerbations, and then you'll have to be admitted. Take note, by the way, rheumatoid arthritis, yes, they affect joints, but remember, the joints aren't the only connective tissues in the body. Okay, so we do have connective tissues everywhere. You have your peritoneum, the pericardium, the kidneys. Every organ in the body has connective tissue. So they can be affected when you have a flare-up. Are we clear? Meaning you will have systemic manifestations in your internal organs as well. Yes.
So if someone were to have an additional autoimmune disease such as HIV, and they were on meds for HIV, and they also had rheumatoid arthritis, they would need to take medications for each condition.
Well, in HIV, remember the treatment for that's caused by a virus causing the immunosuppression. So it's not really, yeah, it's different.
But can the rheumatoid arthritis complicate?
Yes, it will worsen your immunosuppression. But not entirely, because remember, especially the immunomodulators, the IL-1, IL-6, TNF inhibitors, those are more cell-specific, so they don't really affect HIV that much because they're more targeted. Unless you're on steroids, then yeah. Okay, for pain, the only drugs that work for these patients' pain are not opioids. They only respond to NSAIDs because it's inflammatory in nature. So therefore, it doesn't make sense. You give opioid, what for? I mean, this patient has inflammation. So you give anti-inflammatory non-steroidal agents. So NSAIDs, number one side effect is, of course, peptic ulcers. Okay, this is the top cause, or second to the bacteria. So this is high risk. This patient places the patient high risk for peptic ulcer. So in addition to NSAIDs, since they're taking them every day, multiple times a day, and then the patient is not pregnant, they will be placed on misoprostol. No, have you heard of misoprostol? Similar to mephisterone. Anyway, it's an pregnancy, it's an abortion pill.
But that's in the terminal.
So if that's the case, then you'll be placed on here because you're at risk for gastric ulcers or duodenal ulcers. So you'll be placed on either PPIs or H2 receptor blockers. Like Pepcid, cimetidine, or the Prozols. Okay, so to decrease the incidence of ulcers. Okay, because you have to take them every day. We have no choice. We can't take them off those either. Because now what do they have for pain relief? Okay, so we need to protect their stomachs from ulcers. Because that's the consequence of taking NSAIDs for a long time. Please take note in your teachings here, nurse should be aware that NSAIDs do not prevent erosions. So therefore, do they cure the no? Okay, all right. And then again, opioids, here's the rationale. Opioids will just overall not beneficial. Okay, because they're just how do opioids work, by the way? They simply alter your perception of pain. Pain is still there, but can you feel it? No, it tricks your brain tells your brain, no, there's no pain, buddy. I gotcha. Right? That's all opioids do. But NSAIDs, what do? Eliminate the pain because they are prostaglandin inhibitors.
I'm sorry, back to the first you said it's in conjunction with the PPIs and the H2.
No, either.
So it's either or?
Yeah. So patients, childbearing age, we won't put them on misoprostol, okay? Because we know they're sexually active. So therefore, it's not safe, right? So therefore, we can use the PPIs or the H2 receptor blockers. All right, so what if the patient's been RA for a long time? Okay, so now these are our options. So in addition to non-pharmacologic, we now, because this is now, the disease is now progressing. Okay, so after years of trying to keep it from worsening, now it's full blown. So now we almost exclusively use combination drugs. So we've got DMARDs, which means azathioprine or methotrexate, and then one or more of those TNF inhibitors or IL-1 or IL-6, interleukin inhibitors, the expensive medications. Take note that surgery is possible, especially if you have those swan neck deformities, but are they done frequently? No, because plus again, will the surgery cure the problem? No, it'll just remove but then does the inflammation go away? No, the inflammation will persist. So therefore, can it destroy that joint again? Yes, unless of course let's say it's a hip joint, now you have a titanium joint. Of course, there's no more inflammation in titanium, right? Yes.
So like, let's say like those joints that you showed us for in the hands that you just showed us. I've noticed like the knuckles, is it calcified or is that just one?
No, those are, I forgot to mention that. Those are called nodules. They're not really calcified. They're more like fused. Now because of chronic inflammation. Yeah, so the joint is now fused and then you lose function of the joint. Pretty much they don't bend anymore. Meaning they have that permanent deformity. So you can't grab stuff anymore.
They do surgery, what exactly are they doing to the joint?
Just to straighten it back. But then
But you always get inflammation after any orthopedic surgery.
Exactly. So that's why surgery is not very popular. Surgical options instead of repairing the joint is more done to relieve pain. Let's say the joint is very swollen, they'll drain the fluid, right? Or sometimes they'll inject steroids there, okay, to reduce inflammation. Then we have the topical agents are an option also. You give them, the NSAID, they come in lotions. Yeah, Voltaren is diclofenac, which is an NSAID. Okay, so you can use those several times a day. Benefit of topical NSAIDs is as opposed to, NSAIDs, which is, again, ulcers. So you can use local NSAIDs like diclofenac. Okay, obesity considerations. Of course, this will, because with obesity, you have pretty much high inflammation in the body, correct? And that will hasten, facilitate the progression of the disease, not to mention additional weight on the affected joint. So this can exacerbate the condition. And then of course, the quality of life, so much pain, reduces mobility even more and prematurely progresses the disease faster than usual. Plus consequences of if the patient's already obese and then we put them on steroids, right? And then the steroids will increase appetite, increase sugar some more, leading to increasing the BMI. And not to mention the consequences from obesity, cardiac. This is not discussed in this chapter, but that's, another chapter. All right, so we approach the disease multimodal. So we've discussed already nursing care, and no, not nursing care yet. We've only discussed medical management first. So we've got the medication therapy, right? So non-pharmacologic would be intercollaborative therapy with occupational therapy and physical therapy. And we haven't gone to the table for medications yet. Okay, so let's go to patient teaching now. So this is where you come in. So encourage with the help again with collaboration of OT, occupational therapists. They'll suggest some adaptive equipment for these patients, especially those with hand deformities now. So they'll use adaptive devices for eating, for doing ADLs, chores at home, pick up devices, okay? Altering the environment, meaning the toilet seats, because they can't bend too low now. So toilet seats will be raised as a result. Grab bars will be installed in the bathroom and the shower. By the way, between the shower and the bath, what will be recommended for these patients? A bath or a shower? Imagine if you say bath, that means they'll have to lay down, right? Getting up would be a problem. Yeah, it's comfortable. No, you soak the whole body, but then how do you get up? All right. So a shower would be preferred, a hot shower, because joints are really stiff in the morning, very hard to get started. They loosen up, especially if they move. Right. So, we recommend a warm or hot shower, okay, to start the day, loosen the joints, loosen the inflammation, and then they can get going for the day. Here's your teaching. You have a chart. Chart 34-4. This includes balancing activity with rest. Okay, very important because the joints are hot, right? They're inflamed, they're painful. So do you exercise when they're hot and painful? No, you rest them. Okay, so you rest them. So always balance activity with rest. When they feel good, meaning you don't have any joint inflammation, yeah, go ahead and exercise. Keep the joints working, make sure they maintain. Yeah. However, during inflammation, they're hot and swollen. Is that really a good idea to force the exercise? No, you're causing more pain and plus you're causing joint damage now. Okay, so eat healthy. Oh, okay, I remember. The drugs are not exclusively here because they are shared with lupus. Okay, I remember now. Let's go to the table, which I think is found under lupus.
Further down.
34-2. Okay. And 72. Okay. So here are your drugs. Notice the title doesn't say rheumatoid arthritis, right? It just says rheumatic diseases because they cover lupus, they cover systemic sclerosis, they cover multiple sclerosis, and then rheumatoid arthritis. Okay, because those are all rheumatic disorders or diseases. So NSAIDs, we really don't give aspirin anymore. Yeah, I haven't seen RA patients take aspirin. We do encourage NSAIDs. So this is the diclofenac here. This is the topical, the lotion or ointment. Then we've got ibuprofen, no, just like Aleve. Okay. Oh, celecoxib. The benefit of celecoxib, which is a COX-2 inhibitor, versus ibuprofen is COX-2s are less likely to cause ulcers compared to ibuprofen. So COX-2s are celecoxib.
It is expensive also.
Yeah, but at least if you have, a prescription, insurance usually covers that.
But Tylenol is also a COX too.
Tylenol doesn't fall under NSAID though.
But it-
Tylenol is not a anti-inflammatory, has no anti-inflammatory properties. That's the disadvantage of Tylenol. Although we do have Tylenol for arthritis, but again, it's not an NSAID, has no anti-inflammatory benefits. Here's the DMARDs. So starting with the cheapest, okay, we've got methotrexate and hydroxychloroquine. So which ones are testable on this table? No, which part of the table? No, I'm testing all of them. So which part is testable?
The nursing consideration.
It's up to you.
None.
Okay, so the nursing considerations, all right? So the third column is your nursing consideration.
For all these
I got a
medications,
question.
All the drugs listed here.
Sir?
Yes, ma'am.
Anti-malaria? That's where-
Yes, hydroxychloroquine.
Okay,
Yeah.
so it's
Mhm. Yes,
we have to know all these for the next exam.
that's what I said. Yeah.
what is the next exam?
Week 9, March something.
7.
So what did I say at the start? There's not much nursing here. So it's all treated with medication. So it's like a farm test.
Yeah, this is like a pharmacology.
So I'm giving you a heads up. As I mean, there's nothing nursing here. Well, you have the teachings, but pretty much no. I mean, we can't treat arthritis with just therapeutic communication. Hey, how do you feel? It's not going to do anything. Do you want to talk about it? No.
Yes.
They need medications. Unless a salad will, reduce inflammation here. You have pain? Here's a salad. Okay. No, we need to give NSAIDs. We need to give the methotrexate. Right? Any questions? Right, we're almost done. So for the activity, let's go back to rheumatoid arthritis, which is to be here. So let's go to the end. Actually, we finished
Yes.
because we did the teaching, right? We had the chart here. Yeah, so this is the discharge, chart 34-4, page 1082.
That's it. So what do we have next week?
Quiz next week will be on myasthenia gravis and rheumatoid arthritis.
Also,
What about, so sir, what about rheumatoid arthritis? This is just the therapeutic side, right? Not the medication side.